patient with a transverse plane deformity. If you look, you can see the gap she has between her third and second toe. Basically, she got a plantar plate tear. Now, a lot of times, if the toe is totally dislocated, we'll do the Haspel procedure. Now, in the early stages of this type of deformity, you can kind of stay with just the toe. And what you can do is you can come to the side of the toe here, and you make a wedge osteotomy. And it is a biplane osteotomy, so you pull the toe down and over. And you can also facilitate this correction by doing a capsulotomy on the medial aspect. Now, you also have to look at the metatarsal. With this patient, if you look at the x-rays, her x-rays show a clearly elongated second metatarsal. And this is one of the few cases where I'll sometimes perform just an isolated metatarsal osteotomy, which she's going to need today. If you look at her foot, let's have her stand up. Stand up on your foot real quick and we see what's going on with her foot. See how displayed that toe is when she's standing there? That's a pretty bad display right there. Look at it. Her second toe doesn't purchase the ground at all. So with her, it's going to be a little difficult just to do the toe to make this correct. Now you can do a tendon transfer to pull the toe down. Another thing that has to be kind of looked at, sit back up here again, is that if you want to do the minimally invasive procedure here, you don't want to sacrifice any of your plantar pull. So if you were doing Isham hammer toe here, this may not correct the condition because you would lose your ability to plantar flex your toe. You want as much pull down here as you can. So what we're going to do with her, we're going to do this same wedge osteotomy that we've discussed there. We're all going to do a capsule release, and in her case, we're going to do more of a capsule release across it and actually sacrifice the dorsal tendons, so the toe does pull down. And we're going to keep all the plantar tendons intact, so we have pull downward. And we're going to go into the metatarsal, and we're going to also angle the metatarsal cut. So the metatarsal cut is going to be through the bone here, but what we're going to do is take the metatarsal head and push it medial. And what that will do is basically tighten your lateral structures and pull the toe over like that. So we're going to take the metatarsal and slide it that way. The metatarsal cut's going to be here, and we're going to angle it where we have a little bit of a wedge out of the osteotomy like this. And we're also going to transposition it medially, and that will allow this toe to go down and over. So we're going to do both of these osteotomies, leaving all the plantar ligaments and tendons intact. We're going to sacrifice the tendon in the dorsal and the capsulotomy in the dorsal aspect of the second metatarsal phalangeal joint. Okay, we're going to look at the second metatarsal phalangeal joint here. Okay, so if you look at your ligament here, this is your metatarsal joint. You see it's swollen, but the ligament is right here, that darkened area. Now, if I pull the toe apart, you can see that ligament give, and the ligament's right there. This is the tendon on top. That's the plantar plate right there. Watch it kind of separate. See it separate from each other right there? Mm-hmm. And you can see the swelling there. Another thing you do, you take the toe and you can push that toe around plantarly. See, it's not stable. See how that's not stable? Yep. I'm pushing the second toe up and down. You can really see the tear right there. That's the tear in the plantar plate right there. This patient does need a second metatarsal osteotomy. This morning I want to show you a patient that we treated a predislocation syndrome and a plantar plate tear utilizing minimally invasive foot surgery, which we did in the office. Now, the traditional ways of correcting this normally require hospital surgery. Normally, implants can be used, flexor tendon transfers. There's different ways to correct this, even direct repair of plantar plate. We were able to do this in the office under local anesthetic through a minimally invasive procedure, and it takes advantage of several things. So we'll show this to you, show her toe drifting towards the big toe, now how it's not. Okay, so this is her foot now, 8 weeks later. You can see the toe is no longer drifted towards the big toe, and we'll have her stand as well. Now, the way we're able to do this is we can do this by minimally invasive surgery. What we do a tenotomy of the dorsal aspect of the toe. When this is done here, where we do a Z lengthening, and also we do a capsulotomy dorsally. That helps get the proximal phalanx down. We'll also do a osteotomy on the proximal phalanx to pull so that we get toe purchase after this surgery. In addition to this, we do an osteotomy on the metatarsal. Now, one of the things that is the trick here is the way we manipulate the metatarsal. So what we do, after we've done the metatarsal cut, we shift the metatarsal medially. And that way it tightens up your lateral capsules here on your lateral portion and pushes the toe back over. Now this is known as the Johnson modified YY style in open surgery, but we did this in closed in minimally invasive procedure. So we push it over that way. While we kept it in place, we take a K-wire and push that intermedullary here into the second met. And that holds the metatarsal metatarsal head. And we can manipulate this with another K-wire we put in this way to get exact position where we want it to be. Now after the surgery, we can use to ensure that this metatarsal stays medial, we use kinesiology tape to get a gradual pull to manipulate exactly where we want this osteotomy to kind of consolidate. So we're able to kind of correct the plantar plate. Now what we did with this, we looked at our plantar plate with an ultrasound prior to the surgery 8 weeks ago, and now we looked at it again today, and the plantar plate has in fact healed. So I'm going to let the patient stand, and you can see how now she doesn't have any trouble standing and putting weight on it, and the attitude of the toe as well. So here she is standing. You can see we don't have any issues with toe purse. We've got a very straight toe. Push your toe down to the ground. So see now she can still toe purse. That's very important, and that's one of the reasons why we do the osteotomy on the proximal phalanx as well. And we don't cut the plantar tendons, and that way we can continue to have plantar flexion of the toe. So let's just talk to the patient. Now before this surgery, you were having a lot of pain under this second metatarsal right here. Now on a scale from 0 to 10, what was your pain?
About an 8.
About an 8. And that was on a daily basis, right?
Oh, yes.
What is your pain now on the plantar aspect of your foot here?
0.
So you have no pain.
No pain.
So her pain is completely resolved in the plantar aspect of her foot here. Now you were telling me a while ago that one of the things you're having to do is learn to walk on your foot, because before you came to see us, you were having to walk on the side of your foot, right?
Right.
And now you're able to walk kind of flat down.
Right.
Now, and you have a job where you're on your feet a lot, and
yes.
So this was bothering you quite a bit, was it not?
Yes.
Okay. Now, you know, one of the things that we're kind of leaning towards now is office surgery, and your patient pretty much has to pay for your surgery. So this surgery here, I know it was some out-of-pocket expense, but if you'd have had this done at the hospital, it'd have cost you about $12,000. So so that's what and the procedures that are done, that's sort of $12,000. So do you think it's a lot better you can do this in the office?
Absolutely.
Yeah. Would it have been affordable to you to go to the hospital?
No.
You could not have had that done.
Not at
so
all.
if you'd have had to go to the hospital, you pretty much had to live with this.
Right.
So that's what we're kind of gearing the practice towards. And this is also, these procedures can be done in the office. They're the minimal cost. The K-wires cost $10 a piece. So the cost of this surgery was $20 in product, and other than the lidocaine that we use to anesthetize the foot. So basically, we've been able to do a surgery that's affordable for the patient, that corrects the problem, and allows a patient to be able to pay for this when they have deductibles that are high or they have insurance issues. Not everybody still doesn't have insurance, and everybody, like myself, my insurance, my deductible is $10,000. So really, you have to these office-based surgeries serve a great need for the health of the patients, and also it saves our system quite a bit of money as well.